Welcome to everyone who is attending our session today on proven strategies and succeeding with downside risk. We're going to begin our webinar now. A few housekeeping items. Slides will be distributed at the end of the webinar later this week. The event is also being recorded, and for that reason, we do have all lines muted. However, you can use your Q&A box on the right for questions. Throughout the presentation, we will be presenting some polling questions. Those will appear on the right side of the screen. And we'll give about a minute for you to go ahead and respond with an answer. And then, of course, we'll share those results as well. There are a few key takeaways that we'd like to highlight from this particular presentation. One is going to be the best strategy for current position in the risk continuum. We also want you to be able to understand the cost reduction opportunities that you may have within your organization, how to scale care for high-cost, high-risk patients, and lastly, identify, establish, and manage high-performing, low-cost networks. This presentation is divided into 5 sections. The first, we're going to review some industry challenges, then the Medicare shared savings statistics, strategies for success. We're going to review the value-based care playbook. And lastly, what is the path forward based upon some of the information that you received today? Our speakers for today's presentation is Maha Saluhuddin. She is an advisor at Lightbeam Health Solutions. Maha has been responsible for the implementation and go-live of enterprise population health management software for over 15 healthcare organizations, representing nearly 1 million patient lives. Maha has developed extensive value-based care playbooks, ACO roadmaps, and other advisory program initiatives while providing superior support and advice for her clients. We are also joined by Jeffrey Nelson. Jeffrey is the Chief Information and Innovation Officer for all of the companies under the Millennium Healthcare umbrella, including Millennium Physician Group, Millennium Home Care, Millennium Accountable Care Organization, Gulf Coast Accountable Care Network, and the Accountable Care Network of Independent Physicians. Jeffrey has over 20-plus years of experience innovating programs and initiatives in the business and healthcare field. He has been with Millennium for over 9 years in various capacities. Now that we have the introduction, I'm going to turn this over to Jeff to talk about the first portion of the webinar.
Thank you. Again, my name is Jeffrey Nelson, and I wanted to give you a quick overview of Millennium Physician Group and some of the things that we're working on. So Millennium Healthcare, and through its physician group, we've been on the leading edge of value-based care for about the past 8 years, since it really became kind of a topic that people started talking about. And since then, we've actually grown from primary care into multi-specialty, and we've started up and are running 7 ACOs. 3 of them are MSSPs. 1 is a Track 3, 2 are Track 1s. We've got 6 Medicare Advantage plans and programs that we're currently contracted under. We have 375-plus providers, about 257,000 patients now. This just got updated this morning. And we've got about 57% of our patients are in a value-based or a shared savings program. Our corporate headquarters is located in Fort Myers, Florida, and we have 85-plus clinical locations spread out through 10 counties in Florida, which goes from Marco Island in the southwest all the way up to Jacksonville in the northeast of Florida. Go ahead to the next slide. And one of the things that we're very proud of is that every year that we've been in the MSSP track, whether it be Track 1 or Track 3, since 2013, we've actually been on the upside. We've actually earned shared savings in each of those years. And last year, 2017, we actually were #1 ranked in the country by earning just under $30 million in shared savings. That was based off of 42 million generated savings, which put us at #8 ranked in the ACO. However, because we were Track 3 and we decided to take more of the risk, we were able to get more of the earned savings and the shared savings from Medicare.
So we're going to go ahead and proceed with the first poll question. So you should have seen a little pop-up show up on the right side of your screen. And the first question here is, what % of your patient population is in a value-based contract?
Thank you, Maha. We have about 1 minute to review this question, and then we'll share the results on the screen. A few more moments left. And we should have those results momentarily. All right. So the results of the question, what % of your patient population is in a value-based contract? We have 32% with an NA, 41% as 30+%, 10 to 20%. We had 19% of our respondents respond to that particular answer, and 8% responded to 0 to 10%. Thank you all. Now let's continue to move on with the webinar. And the next item that we're going to talk about is the industry challenges. Maha?
Great. So we're going to start off the conversation today with some of the challenges that all of us are facing in the healthcare landscape today. So as you guys are aware, healthcare is an ever-evolving facet, and with this evolution comes new challenges. A real challenge organizations face today is without a population health tool, you really have no visibility into total cost of care. Payers now are starting to provide more financial reports, but this data is still limited. It's difficult to forecast shared savings, MCR, and total cost of care throughout the year for your patients. What we see is value-based care is not going away, right? So policy uncertainty and healthcare reform modifications have provider organizations slowly swapping out traditional fee-for-service for value-based reimbursement. We are seeing more models focused on outcomes driven by early interventions born in the ambulatory settings. We see more models for episodes of care that are not focused on the inpatient setting, but one centered on managing chronic conditions executed by ambulatory care teams. We will likely see more models that center on connecting the dots between cross-functional care teams, such as integrating behavioral health within primary care. And a lot of organizations are still not ready for that shift. Next slide, please. You see here that by 2020, 54% of reimbursements will be tied to value-based payer arrangements. That's that little chart on the left-hand side, with 60% of providers participating in value-based payment models. But there's still a lot of work to be done here. A recent ORC international study found that there's still a mismatch between payers and provider alignment within value-based care, with payers feeling much more comfortable with the upcoming shift with value-based care. And you'll see here that much of the providers' lack of enthusiasm comes from a lack of good data to succeed in value-based programs. So there's lack of alignment based on quality, cost, and care coordination data that's available today. Next slide, please. And what we see is that value-based care is a complete paradigm shift in how you'll be measured to determine reimbursement levels, right? So we anticipate your operations will change, your IT requirements will change, the focus is going to shift for your caregivers. The traditional fee-for-service world rewarded you on volume of procedures you completed. The more you code, the more you got paid. The traditional fee-for-service model required a practice management system to help you manage accounts receivable rather than chronic diseases. They required an EHR to document clinical notes. And now with the shift to value-based care, you'll see you have a greater need to analyze cost and utilization data with the end goal of being able to control your costs. Now you'll be able to analyze claims files from the payer and report on your quality outcomes. Now you're judged on patient satisfaction and CAP scores. There's a greater need today to aggregate clinical and claims data together and produce quality measure outcomes. So we really need to be able to identify high-risk patients and provide ample care management services with the end goal, again, of reducing cost and utilization for your high-risk patients. So in order to succeed in a value-based care world, you really need a transformative solution, a solution that provides end-to-end services that allows you to integrate data from various data sources. This allows you to have real-time visibility into how you're performing month over month, year over year, a tool that allows you to analyze high-cost, high-risk patients, allows you to engage with both your providers and patients by providing real-time data at the point of care. And we believe our solution, Lightbeam Health Solutions, allows you to succeed in a value-based world. A big challenge that many healthcare organizations face is disparate data that doesn't provide a holistic view of the patient's care and your organization's spend. You have data coming in for one patient from claims interface, the EMR, the local HIE, lab data, radiology data, and really no one place to see everything that is going on with the patient. On top of that, the format of the data is not easy to digest. The format of the data that comes from your payer is very different than the format of the data that comes from your HIE, so it ends up requiring more resources on your end in order to interpret that data. So with a pop health tool like Lightbeam, we see that there is no more disparate data. Within a matter of a few clicks, providers and healthcare executives can see a holistic view of the patient and your overall population. We're able to show cost and utilization data for each of your at-risk programs. You now have the insight to see how you are tracking on value-based care programs like annual wellness visits and chronic care management. Dashboards, such as the one displayed, allow you to trend your transitional care management outreach post-discharge, allows you to monitor costs for your high-risk cohorts, allows you to track ER utilization, and really tools like this is what's going to help you succeed and thrive in this value-based care world. And with that, we're going to move into our second poll question.
Exactly. So our second poll question is, which patient populations are you currently managing? Again, you'll see a screen pop up over on the right-hand side where you can record your response, and we'll give everyone about a minute to respond. We have about 30 more seconds. Again, the poll question is, which patient populations are you currently managing? All right, that poll question has now closed. We'll give this just a moment and we'll review the results. Okay, so for the polling question number 2, which patient populations are you currently managing? It looks like by and large, 59% have said MSSP. The next closest percentage is going to be our commercial population at 11%. We have Medicare Advantage at 9%, other at 2%, and 0 for managed Medicaid. Go ahead and close this out, and we'll continue to move forward. Maha, back to you.
Great. So the next area that we're going to cover are the 2017 MSSP results. So how are ACOs like yourself doing in this new evolving atmosphere? Well, back at the end of August, CMS released the 2017 MSSP results, showing how the 472 ACOs performed. Overall, it was a great year for the federal ACO program as a whole in terms of both reducing costs and improving quality. 472 ACOs who cared for about 9 million beneficiaries generated $1.1 billion in gross savings. These savings were generated by 60% of ACOs. $800 million in shared savings bonuses were paid to these ACOs, and a mean quality score of 90.5% was what was accomplished for ACOs under pay-for-performance measurement year. While CMS had a good year in terms of generated returns, we see that LightBeam ACOs led the pack. Over the course of the last 4 years, LightBeam ACOs have generated over $470 million in savings. On average, in 2017, LightBeam ACOs were 1.7 times higher than non-LightBeam ACOs. LightBeam Track 3 ACOs such as Millennium generated 47% of total savings for Track 3 ACOs. So Jeff's team really made CMS very happy by leading the pack and being the #1 ACO in the country in terms of earned savings. And I will let Jeff tell you guys how they got there.
All right, great. But before we move into the strategies for success, we have our third and last poll question. And that question is, how are you currently managing your patient population? All right, so once more, everyone should see a box that opens up over on the right-hand side. And just like previous examples, we're going to go ahead and give everyone a minute to answer and respond to that question. Okay, about 30 seconds left. Again, that polling question is, how are you currently managing your patient population? You can make a selection in the box over to the right and then choose Submit. Okay, that polling question has now closed. We'll give this just a moment for our results to pop up and present, and we'll review those. Okay, so for the question, how are you currently managing your patient population? Looks like about 35% are using a population health vendor currently today. Following closely behind that, 20% are using a claims analytics vendor. We have 18% who are using an in-house solution. And then we have about 5% who are using an EMR vendor, and 3% of you out there are actually currently evaluating vendors. So thank you very much for those responses. I'm going to go ahead and close that screen out, and we will now move over into strategies for success. So Jeffrey, I'll pass it back to you.
Thank you so much. And this is actually a question that I get asked a lot, is, what is Millennium doing? How are they doing it? And what is the focus? And I think it's very important to kind of understand that we've got kind of a four-prong approach and kind of a belief system that it really requires proper tools, processes, the people, and most importantly, the data. And we focus very heavily on data. What is the data telling us? How do we leverage the data? And what can we glean from the data? And I always talk about kind of a holistic view, and it's kind of a holistic view of the patient. And we really are patient-centric in our approach. And if you look at this graphic right here, you'll see on the left-hand side, it all starts with the data, whether it's claims data, clinical data, HIE data, if it could be coming from a clinically integrated network, and other data sources that are out there. And all that data that we have has got to get put someplace for us to be able to really take action on it. And so what we've done is we actually use Lightbeam as a kind of an enterprise data warehouse where all that data flows into it and it kind of gets crunched into an aggregate kind of model, and then we try to normalize the data. And what pops out of that is kind of a risk stratification profile of the patient and of the data. And then we get to start this kind of circular loop where we start to gain insights, whether it be through integrated analytics, artificial intelligence, cohort builder, which we'll talk about in a little bit. And then what the results of those are is care management, physician engagement, HCC coding, patient engagement, and referral management. Everything on the engagement side really has to do with the patient and really understanding what the patients are doing, where they're going, and really how the money is being spent. Because our key is not withholding care from the patients. It's really about getting the patient the right care at the right time in the right care setting. And so that's kind of how we use it, and that's how we use it, the holistic view as we go forward. So it starts with the data and it ends with engagement. And that's been a very big key component for us as we've kind of moved through the cycle over the past several years of really trying to understand this. Let's go to the next slide. So some of the things that we've done as far as our performance is concerned is, number one, we really focus on care management. Again, what is the data telling us about the patients? What can we do for the patients to impact their care, to focus on their care? And we do this through building cohorts or initiatives, and again, we'll talk about it in just a second, how we do that. We also provide to our providers, we actually give them kind of monthly, what we call provider scorecards. And what that does is that gives them financial and utilization data. And those scorecards, which we actually call a GPS report, is very beneficial for the provider because it really gives them the ability to see not only their panel of patients that have been attributed to them, but also gives them the ability to see kind of overall organizationally where we're at. How are we impacting things, like ED readmits? How are we focusing things, like reducing, the SNF admits and other types of things that we focus on. And then it also gives them an idea about quality. Where are they at with their quality? Because everybody knows that with, ACO or even with MA plans or any type of value-based care model, there's always quality metrics and quality performance that you've got to hit, whether it be, statin therapy, BMI, breast cancer, colorectal cancer screening, influenza, those sort of things. We really give the providers the understanding and the ability to see where they're at with their panel of patients, make sure that they're offering the best care while taking number point 3, while we illuminate the care gaps at the point of care. Really the key for the provider is giving them an overview, but also at the time of care, giving them the ability to address some of those issues. Have they had their flu shot? Have they had their, breast cancer screening? Have they had their colonoscopy done? Things that are important that, if it's done and caught early, can really help the patient, the care of the patient. The other thing that we do is we focus very heavily on the post-acute care patient follow-up. This goes back to care management. When a patient is discharged from the hospital or an acute care setting, what's the proper manner of have they gone to a SNF? Have they gone to an ALF? Have they gone to home health? Where have they gone to? Then we actually follow them with our care managers in our care management program through the whole cycle of post-acute care, even so much so as transitional care management, getting them in to see their provider, and other components like that. And then last, we really focus on HCC and HEDIS coding gaps. A lot of times the providers provide the quality service or they provide, the quality gaps, but they really don't code properly, or they haven't coded in the encounter because the EMRs kind of suck for this sort of thing. And so we actually give them a view and we help them through understanding what they need to do for improving their coding. Let's go to the next slide. So dedicated care management, this is really, I think, the key for us is being able to really have a dedicated care management program. Remember, one of the things I talked about was having the tools and then also the people. And this people initiative includes kind of focused cohort initiatives. So we developed through Lightbeam cohorts or segments of the population based upon the data we're seeing. And what we've done is we focus on a lot of various areas. Number one is we put in place a 24/7 care team. Patients that are in any of our programs have access to a care team member, a nurse, a provider, somebody that's there 24/7 to make sure that they're getting the care that they need. And what this does is this allows us to really focus on the frequent ED utilizers, especially where we're at in Southwest Florida. A lot of the ED visits are avoidable. We have had examples where we've had an elderly patient has just lost her husband, is lonely, goes to the ER 12 times in 1 month because she needs somebody to talk to. They use it as their counseling session or they use it as their social hour. Really things that the ER and the ED is not really utilized for. We found that the 24/7 care team access has really given the patients the ability to reach out to somebody and really assess their condition, talk to them, do they really need to go to the ER? Do they really, is this a critical issue that they need to work on? And if so, we'll get them right, we'll get them right to the ER, we'll get them to a provider on call. We'll do a lot of things that happen because it's amazing what happens, between, this time period. And we've actually reduced our ED metrics significantly by putting this one measure in place. So what we thought was going to be a huge cost actually turned into a huge savings for us. We also focus on CHF, COPD, diabetic, ESRD, and then we also focus very heavily on our top 5% of the spend of the patients. And typically, a lot of those costs can be avoided. What we find a lot of times is, especially with specialists, with somebody that's got a chronic condition, specialists will, they'll have an overutilization of labs or testing. And so by focusing on those top 5%, we can get a really good idea of where the spending is happening and really where the care is going and the care, care management for that patient. So let's go to the next slide. So one of the things that I talked about a little bit earlier was kind of a monthly scorecard. What does the monthly scorecard consist of? And basically all of our providers and our PCPs and even some of our specialists now are really getting a scorecard. And what it is a per member per month cost analysis of their panel of patients that have been attributed to them. We focus on ED, SNF, ALF admits, inpatient, quality performance. One of the big ones we're focusing on right now is SNF spending, professional Part B cost. We've also started looking at Part D costs to be able to see how we can potentially help reduce that. And it also gives them an overall risk score based upon the ACG about their population and kind of where they're at overall. And our providers really have bought into this. And we've been doing this for several years now, but getting the provider engaged at this level has been very important for us as we continue to move forward in this program. Let's go to the next slide. So care gaps at the point of care. One of the things that's very important, again, also is giving the providers the right data at the right time and being able to understand what they need to do at the point of care and basically reconciling the point of care. So every patient, let's say they're in an MSSP ACO attributed model, there's certain things that we've got to do from a quality perspective. So we want to make sure we're reconciling those at the point of care. So we've got to give them, basically a gap analysis report so that way they can see what they need to do. We also can take a look at what Lightbeam's telling us versus what the payers tell us. Believe it or not, payers do lie. Their data is not accurate, and a lot of times we've got to show them, based upon Lightbeam data, that, hey, we've taken care of this, whether it came through our clinical data or another data source. We've got to be able to go back to our payers and look at that. And we do a lot of what we call code scrubbing. We go through, we look at the patient's charts, the coding, and make sure that the proper things are being coded in the proper way to really close those care gaps and also identify care gaps that might have been missed with the patient and the patient population. We also use SSRS reporting that gives us open care gaps by PCP, focus HCC HEDIS measures, and other components that are going to be important for tying the quality to the patient, to the provider, and then ultimately to the care team that's supporting the provider. Go to the next slide. So one of the things I mentioned was patient discharge and follow-up. One of the things that we've done is we've actually worked up, most of our patients are located in Florida. We've got a lot of snowbirds that come down. Snowbird, in case of those that don't know, are the ones that come from the cold climates in the winter down to Florida. They clog up our roads and they make it hard for us to get anywhere we need to get to, but we still love them because we need them. But what we've done is we've actually worked with the Florida HIE, and they've got an event notification system that we've been able to integrate into LightBeam. And what happens is when a patient is, when they're admitted into the ER, we get notified. And it's almost a real-time notification. And what happens is the care team inside of LightBeam is given, we built a cohort, and when a event happens through the event notification system, the care team is notified and they jump into action. And so when a patient's discharged from the ER or the acute care setting, our care team members know right away, and they're able to jump into action to help that patient transition from either the ER or the acute care component into a different facility to help them with their recovery and with their care. We also, weekly, we focus on real-time data. That could be admissions per 1,000, ED per 1,000, using HIE discharges, and other metrics that we operate under and we look at. And this is more at an administrative level, physician level, all the way down to the care management team level. We focus on these weekly and give everybody weekly insight as to what's going on with our population of patients. And this is not only for the ACO, but also through the MA plans and other plans that we're focusing on as we're moving more towards risk. And then, like I said, we've got a dedicated care team for post-acute care, 24/7 access. The patients can get to somebody anytime they need to, 24/7, 365 days a year. We give them access to that. So go ahead to the next slide. Another area that we focus on is HCC coding gaps. We actually do what we call chart scrubs, and what that is where we go in and we identify coding opportunities or quality initiatives that need to be happen or need to be closed 7 days prior to employment. We'll go in and actually look at all the information that the patient has. We'll go and we'll look at LightBeam. We'll go and look at the payer data. We'll do a bunch of different things to make sure that we are identifying what needs to happen prior to that visit. Then we actually do a code follow-up 3 to 7 days after the appointment, just to make sure that the proper care and the proper coding was done for the care to make sure that we are reporting it properly. We have found that we do a lot of work that, especially on the quality side, that we were not capturing properly and we were not getting credit for because it wasn't coded properly. Whether it be BMI, BP, some of the things are kind of hard to report out because the providers don't know what codes to use. We found that we were leaving a lot of quality gaps open when they should have been closed. And then what we do is we actually have an alert system via the EMR system that we utilize to notify the provider and the care team at the point of care for areas that they can improve upon when it comes to the HCC coding. Go to the next slide. So what's next for Millennium? Well, this is actually kind of a tough question to ask because obviously, as everyone knows, CMS keeps changing the game on us. In fact, now with the proposed rule with the basic and the enhanced ACO tracks and killing the 1, 2, and 3s, we've got to figure out different ways to operate. And one of the things that we found is that we need to have better integration with the HCC face sheet at the point of care. Right now, the HCC face sheet that we get out of LightBeam is not 100% integrated into the EMR for the point of care servicing and the ability to close it out at the point of care. So we're going to be working with LightBeam on that. We need to have quicker gap closure via EMR and claims data. One of the things that LightBeam has done very well is being able to take the data from the EMR and also the claims and be able to kind of bring those two together. And now we're going to be working on making sure that we have a faster gap closure. If we focus just on claims data, and I think this has been a key for us, is everybody knows the claims data is delayed for a period of time. It could be 2 months, 3 months, 1 month, 6 months, depends upon the payer. By getting the EMR data in and the information in the EMR data, even doing what we call kind of a soft close of the gap, of the quality gap, it at least gives us an idea so we can start benchmarking where we're at and where we need to go. An example is we know right now how many of our HCC care gaps on a percentage has been completed this year, and we also have a really good idea of our star scoring for our MA plans, and we track that throughout the year. And so we need to do a better job of closing that quicker and being able to really use the data a lot better. We're going to enhance our post-acute care coordination. That is one of the things that we found that prevents readmits. That's one of the key killers of cost is when a patient gets readmitted, or when a patient gets to a SNF and they stay at the SNF for a lot longer than they need to. Focusing things like on home care, transitional care management, ALFs and other things that are not necessarily as costly as a SNF. And what we found is a lot of patients who go to SNF, we need to get them out of the SNF and into a different care setting because it's just not an appropriate place for them to have care being done on them. We're also going to be obviously moving to the enhanced ACO track. We're going to be moving more to a total risk-based contracting. We're actually in contracts right now, or in contact, and we're in talks right now with a lot of our payers about going complete risk. We feel that we're at a point in our life cycle as an organization and understanding how to utilize the system, the tools, the process, the people, so we can start taking on more risk and really get into risk-based contracting. We think that's where, obviously, the industry is going, and CMS really has stated that by their proposed change to the ACO tracks, by moving everybody and forcing everybody to kind of take on risk at a certain point in time. We need to engage the patients more. It's about the provider and the patient and that engagement cycle, and everything around that is to support that kind of what I call relationship between the patient and the provider. Patient engagement is very critical. We're going to be working on some really cool AI technologies coming up down the pipeline that are going to really start to show the patient, not necessarily from a reactive perspective what their care is, but more of a proactive. If you make these changes now, this is what your health could be like. If you're pre-diabetic, if you make these changes to your lifestyle now, you'll be able to avoid, full-blown diabetes or, CHF or other types of scenarios that can be prevented. So we're going to really be focusing on preventative scenarios for the patients through more engagement. And then one of the things that we've recently done through an acquisition is we've actually started leveraging Lightbeam's client services, specifically their chronic care management program. So in June and July, actually in June, we went through an acquisition process where we acquired a group that had 40-plus providers in the group here locally in the Fort Myers area, and they were using another entity for their care management, or for their chronic care management program that suddenly went out of business in June, right before the acquisition happened. I mean, it was like the perfect storm. So we were sitting there, it was June 24th, we were sitting there figuring out what we were going to do. We called Lightbeam and said, hey guys, let's talk about your client services, and specifically when it came to the chronic care management. And let's go to the next slide. And what we were able to do is we actually did a rollout strategy, and I'll kind of go into this in just a second about how we kind of did a phased approach, kind of detailed checklist, and kind of how we rolled out the chronic care management for the cohort of patients that came from that acquisition that were already in a chronic care management program that we had to switch them over. Now, if anybody knows chronic care management, they know that the relationship that the patient has with their care management staff member is extremely critical. So that was severed. So not only did these patients go to a new organization, they also now lost the continuity with their chronic care management staff. So it was kind of a complete reset for them. And in Millennium, on the other side with Millennium patients, we've actually done it ourselves internally, but we're actually going to be looking at some point shifting all of our patients over to the Lightbeam chronic care management through their client services program to make sure that we're having a continuity of care through the process. So I'm going to turn it over to Maha real quick so she can talk to you a little bit about what the Lightbeam client services consist of.
Yep, thank you, Jeff. So obviously, in addition to controlling costs, there's still fee-for-service opportunities that exist while at the same time lowering your long-term expenditures and slowing down the chronic disease exacerbation and possible readmissions that could exist. So many of our clients perform annual wellness visits on their population, ensuring that they close care gaps and, at the same time gain fee-for-service revenue. And while we all agree that programs like annual wellness visits, CCM, and TCM are beneficial to our patients, we may not always have the infrastructure and workforce to carry out these initiatives, right? So the example that Jeff gave of that practice with the 40 providers, that's a prime example. So Lightbeam Client Service, this is where Lightbeam Client Services comes in. So it's meant to be an extension of your current care team. We work within your native EMR environment to carry out all the patient outreach, ensuring little disruption to your current workflow and little ramp-up time. So as Jeff will touch on, we were able to launch CCM outreach for their patients within a month and a half. Patients will get a phone call from a registered clinician, and the registered clinician will carry out the bulk of the requirements besides the face-to-face visit. And that's what you're seeing on the screen here. Lightbeam will complete all but the 3 bold blue areas, so which is the face-to-face visits, the care plan approval and periodic review for the CCM tasks, and then for the transitional care management, the face-to-face visit that needs to take place with the PCP. So we carry out these services for your whole population or a subset of your population, as we did for Millennium. And the Millennium team has launched Lightbeam Client Services, like Jeff mentioned, to manage their chronic care management population. So I'll let Jeff talk about some of the successes that they've had since they've ramped up about 2 months back.
Yeah, so we actually had, we actually had a very small window of opportunity. So the group that we were talking about had several thousand patients that were under chronic care management through the entity that went kind of belly up very quickly on us. So from July 1st, when the acquisition was final, we had basically about a week to get something in place for them. We actually had all the clinics were shut down for a week while we did the training transition, got everything in place. We'll talk about our strategy about how we do an acquisition. It's a whole other conversation. But we had until July 9th to get this program up and running. And what we were able to do is we were able to identify the patients, pull the cohort of patients out, and in July, Lightbeam Client Services was able to ramp up very quickly during the month of July, and they did 4,511 outbound calls to the patients in July, and they had a 23% contact rate, and we were able to bill for 84.8% of those. That's a pretty high rate considering we were in mass chaos, panic mode, trying to figure out what we're going to do with these patients. We knew we couldn't do it internally. We knew we couldn't staff up internally to be able to do that. And so we reached out to the Lightbeam Client Services for the CCM management. And the first month we said, okay, great, that was good. Was this a fluke? We went into August, and all of a sudden the calls started going up higher. We had 7,119 outbound calls, 20% contact rate, so 20% contact rate is pretty high, and then we had 88.3% of those were billable. And so between July and August, we actually were able to bill for 2,127 CCM visits, which equated to $90,227-ish, around, it might have been a little bit higher depending upon if some of them were, a little bit more than the 20-minute visit. However, the point here is that Lightbeam Client Services ramped up very quickly for us, and we're actually on target for September to continue at kind of an upward swing. So we really had nothing in place for these patients. In a week, we started a ramp-up process very quickly with Lightbeam, and then from there, it just has kind of taken off. So go ahead, back to Maha.
So Jeff has definitely covered what works for Millennium and the programs they have implemented that have allowed them to manage their patient populations and decrease their overall costs. We encourage all of our clients to do all of these initiatives, but realize that not every organization has 16 HCC coders or a 24/7 care team. So our advisory team works with our clients to tailor a personalized roadmap that accounts for your staff and your individual goals. Next slide, please. So the advisory team provides end-to-end consultations supporting your organization from patient recruitment to all the way up to care management. We provide organizational consulting, helping you goal set and provide an ROI analysis. We help you with plan management, discussing ways to grow your patient population, while at the same time helping you identify HCC coding opportunities. We help with care management, ensuring you're able to identify your high-risk, high-need patients. And then, of course, identifying behavioral health needs for your population. And then lastly, we talk about workflow optimization. So LightBeam is not meant to be a burdensome tool. It's meant to be a tool that integrates nicely into your current workflow. So we designed a very prescriptive program tied to your objectives. If your goal is to focus on COPD patients, we'll help you identify your COPD patients, risk stratify the population to ensure that you get the most bang for your buck in terms of care management. We'll help your staff develop a personalized care plan for your patients. And then the application will notify them each time a new patient with COPD is identified using your data. So it is meant to be a closed loop system. A prime example of a cohort that we recommend to all clients, including Millennium, is to focus on your top 3 to 5% of your population. So what we've seen consistently across all of our clients is the top 3% usually accounts from anywhere from 35 to 50% of total spend. So you can see in this client example, 427 patients represented 3% of their population and accounted for 44% of total spend. And if we go to the next slide, we'll start to see some more insight into this population. So this top 3% for this group, and this is based on actual client data, represents about $13.7 million in spend over a 8-month range from January to September 2017. The average ACG risk score for this group was 6.96. So that means these patients are expected to cost almost 7 times more than your average population. You'll see that total spend per member per month for this group was about $3,000, and these 427 patients accounted for 62% of total bed days for this population that was almost 14,000 patients. So how do we identify these populations? So Jeff mentioned early on that their team builds cohorts and they use the cohort builder. And our cohort builder is really what allows you to slice and dice your patient population by chronic disease, risk score, ER visits, inpatient admits, and more. And then what it allows you to do is automatically assign a care manager and a care plan to manage these patients. At the same time, you're able to assign tasks to the care team to help manage the disease. Once a cohort is created in the cohort builder, all members who meet the criteria can be tracked and managed throughout the cohort life cycle, whether it's a static snapshot of your patient population or an ongoing cohort enrollment. As an ACO, you'll want to manage your chronically ill, high-risk patient populations, right? So here's an example of our cohort builder, and our LightBeam cohort builder enables your team to do that with the automated rules engine that is built in. So here's an example of a cohort that we built. The widget capability allows you within seconds to identify the specific population you want to focus in on. So in this example, we're looking for patients over the age of 65 with a risk score of 5 or more who have hypertension and diabetes and have had at least 3 ER visits in the last year. So this is a very specific cohort, and populations can definitely narrow in on a very small subset of their population like this, but we also start with other cohorts like let's identify your high-risk CHF patients or let's identify your high-risk COPD patients. Another area that LightBeam provides visibility into is your HCC increase. So hierarchical condition categories, or HCC coding, helps communicate patient complexity and helps paint a picture of the whole patient. In addition to helping predict healthcare utilization, RAF, or risk adjustment factor scores, are used to risk adjust quality and cost metrics for your population. So the CMS HCC model was initiated in 2004, but as you guys are aware, it's becoming increasingly prevalent as the environment shifts towards value-based payment models. Along with demographic factors such as age and gender, insurance companies are now using HCC coding to assign a patient's RAF score. So we know that CMS resets a patient's RAF score every year. So organizations such as yours really need a tool that shows where there's coding gaps based on your claims and clinical data. So your LightBeam advisor will help you identify HCC coding opportunities to ensure that you can increase your overall RAF score for your population. We will help you identify key HCC categories such as COPD, CHF, diabetes. And in addition, I help you identify top patients that have the most outstanding coding gaps in your population. So in addition to identifying high-risk patients and coding opportunities, we also help you identify fee-for-service initiatives. So we talked about one of these throughout the presentation, which is CCM. But CMS actually has over 20 preventive services they reimburse providers for. So using LightBeam application, we're able to identify which patients fall into each of those preventive services and are still due. So maybe we need to reach out to patients who are still due for advanced care planning discussions, and we can very quickly identify that patient population and tie it back to an ROI to make sure that you're focusing on the right fee-for-service initiatives. So I mentioned a lot of different initiatives that I work with clients like Millennium on, and in reality, advisory helps you move along the path to value-based care success. Each of the areas here build upon each other, so you really cannot deploy a fee-for-service program and gain value-based revenue without first having physician alignment and engagement. And Jeff touched on that early on in the presentation, right? They give their GPS scorecards and monthly scorecards to their providers, so their providers have some skin in the game. You really cannot focus on building a post-acute network without first having programs like transitional care management deployed to track your discharges and understand where your patients are going. So each of these areas really builds upon each other, and my role as an advisor here at LightBeam is to really help you succeed along the value-based care continuum.
Thank you, Maha. So let's talk about the path forward. For those of you who are going to be attending NACOS, we will be there. Here listed is our booth number, and if you are going to be there, please come by and visit us in the booth. We'll actually be performing free ACO risk consultations. For those of you who may not be going to NACOS, but still want to have an opportunity to do that consultation, we will be including a link in our email at the very end of the presentation. So all of you on the line will receive an email, and that will have a link so that you can go in and you can take that survey, as well as you can go ahead and you can preview the information as well. In addition, we have many different resources that we're providing with you, to you today. For those of you who may not have noticed yet, in the chat window, we have several of those free resources listed out. So please take an opportunity to look through those, see if there's any that you'd like some more information on. All of them have links that you can select, and it'll take you directly over to the resource as well. And then lastly, we're going to move over into our questions. So one of the first questions that we have is, we are a new Track 1 ACO, and what are some of the good initiatives to pursue if we don't have the capacity to cover the diabetes, CHF, smoking cessation, obesity, all of these at once? What's the best place to start? So Jeff or Maha, would you like to respond?
I can take that. So usually good places to start for a Medicare population is CHF or COPD. What we see on average is a high-risk CHF patient costs you about $5,000 per member per month. And the studies have shown that a well-managed CHF patient is about $2,500. So there's an opportunity to cut those costs in about 50% just by having a care manager reach out telephonically. So this doesn't even need to be a face-to-face visit. It's over the phone. Every 2 weeks, just check in with the patient to make sure that symptoms aren't exacerbated, patients are taking their medicine, they have a plan in place if they do have a cardiac event and they need to go into the hospital. But we've seen about 50% savings in cost just from telephonic case management of your congestive heart failure patients. And usually it's a small patient population, so it's not going to be 1,000 patients. It'll be somewhere between 300 to 500 patients, depending on how many care managers you have.
Okay, great. Thank you, Maha. The next question is actually for Jeff. First, congratulations on your success. It's very impressive, but we have three key questions. The first one is, what is your EMR platform? The second one is, what's the percent of Medicare business that is full risk? And then lastly, the percent of providers employed versus affiliated versus IPA. And Jeff, I can repeat each one of those if I need to for you.
Nope, I got it. So we basically, in our makeup, so if we look at the Millennium ACO, that ACO was designed, we are on a single EMR platform, and it's athenahealth. The other ACOs, we manage two other affiliate ACOs that are MSSP Track 1 ACOs, and they've got multi-platform, probably about another 20-ish or so different EMRs that are there. The Medicare full risk component of it, we're moving towards the full risk in a lot of our contracts. In Medicare, we're not at full risk yet. Obviously, with the Track 3, that's taking on a significant amount of risk in the ACO world. In our MA plans, we are going to be going to full risk in 2019 from Millennium's perspective. And then to answer the question about employed versus non-employed or through an IPA, the Millennium ACO, all of the physicians are employed by Millennium. In the affiliate ACOs, obviously they're employed by, other groups or the practices that they're contracted with the affiliate ACOs that we manage.
Great. Thank you, Jeff. The next question is for Jeff as well. And the question is, what do you include on your financial and utilization data scorecards? And are those scorecards PCP-centric, or do you provide specialty-specific GPS reports as well?
So the answer to the last question, I'll answer the last question first. We provide, we have a PCP-centric, but we also have specialty-specific GPS reports. So we do have them kind of both ways. And what we include in the GPS reports is a couple of components. Number one is we obviously want to focus on, what is our per member per month cost of the previous month, when they get the GPS report. Then we also do per member per year cost, comparing it to the year over year. And it's really about trending the cost in several different categories that we look at, whether it's, Part A, Part B, readmission cost. And then on the quality side of it, we do include, all of the quality utilization metrics that the provider will need to hit throughout, the time period or throughout the year. And we kind of give them an emphasis of where they're at, previous month, current month, and then where they need to be at from a CMS perspective. So I don't know if that answered the question directly, but it's kind of a multi-pronged approach when it comes to the GPS report.
Thank you. And Jeff, again, this next one is for you as well. You mentioned the importance of physician engagement. How do you evaluate physician engagement, and how do you know you are there?
So, and that's actually a very interesting question. So I think, number one is obviously if the physicians are not engaged, the GPS reports will show that. And so we utilize the GPS reports, number one, as one tool of an engagement with the physician. Number two, we actually listen to the patients. We do a lot of outreach to the patients, their panel of patients. We do a lot of surveying of the patients, and they tell us, if they feel that their physicians engage with their care. But most importantly is that all of our programs, our care management programs, all the programs we've designed and we've developed are centered around the physician. So kind of by default, the physician's almost kind of forced into the engagement because the care team around them, their attributed lives that they're responsible for, the care team kind of, cocoons the providers. So they really are kind of almost a forced engagement. And I think it's also I think really what's important along with that is being able to tell them the story of the why it's important to do this, why it's important to be engaged with your patients. And it's not about, finances. It's not about quality metrics. At the core essence of it is why they got into medicine. It's what I call the sanctity of that relationship between the provider and the patient. There's been so much noise over the years within a lot of various spaces of healthcare that have kind of gotten away from that relationship. So we really tell the story about how they can be better engaged with their patients, and then that kind of also proxies in the engagement with the physician.
All right, well, I think with that, we are going to wrap up our session for today. Thank you, everyone, for joining. We will actually get back to you with responses for those of you who typed questions into the QA box, but we were not able to answer them. And please, if you have any questions on next steps, how to get in touch with Lightbeam, please type those questions into the chat, and please reach out to George Miranda. His information is in the chat box. Additionally, you can connect directly with Jeff and I as well. We've included our LinkedIn profiles. If you have any questions, please reach out. We appreciate everyone hopping on today, and we hope to hear from you soon.
All right, thank you, everyone.
Thank you, everybody.